Hello, my name is David Lee, and I'm an emergency physician at the New York University School of Medicine. I'd like to introduce you to our study, which uses a novel geographic method and emergency department data to track the prevalence of chronic disease. Traditional methods of tracking chronic disease have largely relied on performing telephone-based health surveys or other methods of sampling large populations. However, unless a large number of individuals are surveyed, it can be difficult to determine disease burden in small geographic areas, and year-to-year estimates can have significant noise due to small sample sizes. With the increasing use of big data and the availability of large administrative data sets with clinical data, there is opportunity to create more precise measures of population health. Though these methods only track individuals who register a medical claim, a significant proportion of the population interacts with the healthcare system. In fact, approximately 1 in 5 Americans report having gone to an emergency department in the past year. Even before I meet my patients in the ER, a medical history has been taken at triage, including questions about health-related behaviors and chronic disease conditions. It's as if 1/5 of the entire U.S. population answers a health survey at least once a year. The objective of our study was to determine whether we could use administrative claims data from emergency department visits to estimate chronic disease prevalence at a local geographic level. We identified the proportion of unique emergency department patients who had a diagnosis of diabetes, hypertension, or asthma coded during any emergency department visit using an administrative claims database of patients residing in New York City from 2009 to 2012. We use SPARTS, which is a comprehensive all-payer database of medical claims in New York State. It contains unique identifiers which allowed us to identify visits by the same patient even at different emergency departments. It also has detailed address level information which we used to locate where patients lived. We compared our estimates to the Community Health Survey, a validated telephone health survey. It samples the population within several New York City neighborhoods. In addition, we used the American Community Survey to compare our study population against census data. Our primary outcome was the correlation of neighborhood-level, age-adjusted chronic disease prevalence between the New York City Community Health Survey and our method of emergency department surveillance. Between 2009 and 2012, the New York City Community Health Survey studied over 36,000 New York City adults, which is a large number for a telephone-based survey. However, we identified nearly 4.4 million unique New York City adults who visited an emergency department at least once during our 4-year study period. This represented a substantial percentage of the estimated 6.5 million adults in New York City. Comparing the age and gender distributions of our data to census data, we found that our population of unique emergency department patients to be extremely similar to census estimates. Looking at our primary outcome, we found that age-adjusted prevalence of diabetes, hypertension, and asthma by New York City neighborhood correlated well when comparing our method of emergency department surveillance to the New York City Community Health Survey. Mapping our results for diabetes, we see roughly similar patterns of chronic disease prevalence based on the New York City Community Health Survey on the left and emergency department surveillance on the right. In addition, when we looked over time, we found marked year-to-year variability in the estimates of diabetes prevalence by New York City neighborhood based on the Community Health Survey. In contrast, our larger population using emergency department surveillance led to more stable estimates that exhibited less variation over time. Using address-level information in our method, we were also able to map chronic disease prevalence at a much more granular level than is possible using currently available data sources. We found that our method of emergency department surveillance may have higher reliability over time and greater granularity to determine chronic disease prevalence at a local level. However, there are good reasons to perform well-validated surveys like the New York City Community Health Survey. They can collect more specific information not available in large administrative claims databases. Further research should be done to validate our methods for regions outside of New York City. Our approach could be especially useful in areas where population-based health surveillance is not regularly performed. Additional studies should expand these methods to other diseases. Doing so would allow for monitoring diseases not usually included in health surveys. Now that variation in chronic disease prevalence can be characterized in small geographic areas, further research should be done to determine what factors drive high disease burden in local communities. More importantly, we must identify what is unique about those regions that would be expected to have high diabetes prevalence based on socioeconomic factors, but actually have lower than expected rates of diabetes. Doing so may help us identify those factors that protect certain communities against chronic disease, which may give us hope and strategies to help areas where chronic disease burden is overwhelming. Thank you so much for learning about our study. I'd like to thank my co-authors and study funders for their essential support. For additional details, please see our manuscript in full at the American Journal of Public Health.